Mike, good morning to you.
Good morning. Yes, I think I'm on my third platform.
You can hear us good. Mike, I think we've got something in common. Both of us have fathers who are in the merchant marine, and I think having an upbringing like that sort of inbuilds a thirst to explore. Would you agree?
Yeah, absolutely. My grandmother had a shrine in her front room, the good room. You know, every house has a good room in a working class community, and the good room was full of mementos and ornaments. And he bought her a lifelong subscription to National Geographic, and I used to spend my days with my grandparents sitting in this altar to my father and looking at magnificent images in National Geographic while other kids were completely unaware of the rest of the world.
And Mike, it's a real honour to have you join us today. And I've got, before I hand over to the WEM Medical Director, Will Duffin, I've got one question of my own. You know, as an epidemiologist and a former trauma surgeon, how did you end up being the Executive Director at the World Health Organization for the Emergencies Plan? Tell us your story, because there are so many people in the audience here who would be inspired to follow the pathway that you've trodden.
Yeah, well, if you call it a pathway, entirely unplanned. Sliding doors, I think, is the only way I could describe it. Maybe a thirst for adventure and travel and to experience other cultures, and that sort of drives you forward. But certainly moving from surgery, which I was in training for, into public health wasn't necessarily a choice. And I was badly injured in a four-wheel drive accident, and that pathway closed down for me while I was in Iraq, and I moved into public health. How I got here is just a series of serendipitous events, and you know, it's amazing. It's the good things and bad things in your life that change the direction of your life, and sometimes it's the bad things. Sometimes a pathway is thrust upon you. I have to say, when my preferred pathway in medicine was blocked, I spent months and months in despair. I had invested so much. My family had invested so much in my education and my training, and I was the first person in my family ever to go to university. And here I was lying on the side of a road in Iraq with a multiply fractured spine and my career in tatters. So to come back from that and to find your way, and I'm sure all of you in the room, anyone who works at the extreme end of the business we operate in, has had those dark moments of the soul and those moments of despair. But sometimes it's from there that you rebuild, and sometimes the new pathway is better.
It's an incredibly peripatetic career pathway that you followed, but it's remarkable. Your story is absolutely remarkable. Now, I'm conscious of time, so I'm going to hand over to Will Duffin. But Mike, thank you so much for joining. It is a real honour to have you join us here this morning. So I'll hand over to Will. Thank you, Mike.
Thank you.
Fabulous. Thanks very much, Mark. Mike, it's a huge honour and privilege that you're able to join us today. Thank you.
It's good to be here.
Excellent. So I'm a jobbing GP based in Devon, and my colleague Claire, who's a HEMS paramedic, we're going to fire some questions at you, Mike, if that's okay. And I've got some questions I'm going to ask you myself. We're going to take questions from the floor, and we're going to take questions through the Swap Card app. Now, I do apologise, there has been a change to the schedule. So if you want to submit your questions to Mike, whether you're here in person or whether you're watching virtually, if you submit that in the current live stream session, so that's actually Nick Danziger's from Pyongyang to Kabul session. So it's a bit confusing, but the current live stream session, that's where I want you to put your questions or comments for Mike Ryan. Now, just to give this some structure, we're going to divide our Q&A into the following 5 categories. So we're going to start with your career, Mike. We're going to talk about that. Then we're going to move on to COVID-19 related topics. Couldn't be a hotter topic at the moment. Then we're going to talk about global and public health. Point 4, we're going to look at the future and what you think where the world is going and what's next. And this ties in with our conference theme, A New World Awaits. And finally, there'll be some fun questions. This is your opportunity to ask Mike anything you like. So we keep it respectful, but we can have a bit of fun, and we can, any miscellaneous questions will come in there. So please send your questions through the Swapcard app if you're online. We absolutely love hearing from you. Let's get started. Is that all okay with you, Mike?
Fine with me.
Excellent. Okay, first question. So you started your medical career as a trauma surgeon. Then in 1990, whilst out in Iraq, your vehicle was run off the road by a military convoy, leading to multiple crushed vertebrae. You could no longer operate as a surgeon, and this is when you retrained in public health. Can you tell us how you dealt with this period of adversity in your life and how you were able to reinvent yourself on this bold new trajectory?
I sort of alluded to it before. I think everyone likes to think that they respond very functionally to these huge challenges in life. I don't think I necessarily did. Many of us who were hostages in Iraq not only had to rebuild our brains, not just our backs and our bodies after that experience. So it was a challenge. I wasn't a fully qualified surgeon at that time. I was in what is called resident registrar's training program in surgery. I was actually on my way to Australia, to the Royal Prince Alfred Hospital in Sydney, and stopped off in Iraq to do some work and maybe help pay off some education loans, and having to work there for 6 months in under sort of hostage conditions. But then the car accident changed everything. Coming back home and just seeing your colleagues move in and move on to their next phase of their careers, as you sort of lay there trying to recover, and knowing that you just couldn't take the pressures of that work and the time it would take to rehabilitate was never going to be good for surgery. So to be honest, I have to tell you, I was depressed. I felt like not my life was over, but all of this time had been wasted. And sometimes in life you just need friends and family and others to give you a boot in the arse, and just get on with it. It's not that bad. You're still a doctor. You still have your life ahead of you. And I actually volunteered to go and work in a local university public health department doing surveys. And it was more for therapy for me than any scientific interest on my part. And it just went from there to a master's in Dublin, and then doing higher specialist training in communicable diseases in the UK. But I'd like to think I had a great plan, and I just had a really bad time, and then I made a plan to do better, and I changed, and everything was under my control. It wasn't. There are moments in your life when you're a mastless ship at sea in a storm, and whether you survive or not may be down to you, but sometimes it's down to the helping hands of others and the lighthouses that people give you to guide you home. So a mixture of the two, and I think we should never, ever believe that our success is down to ourselves. Sometimes it's the hand that reaches out to you that guides you to the light,
Yeah, thanks, Mike. That really brings to mind that famous quote that the winds always favour the ablest of navigators. And it sounds that you were able to identify what's in your locus of control to get yourself out of that tight spot and ultimately build the most incredible career. So we've got Mike Ryan on the line. He is for those of you who missed the first part of this, he's the WHO Emergencies Chief, often described in the media as the fireman of global health. Does anyone from the floor have a question for Mike? If so, please raise your hand. Any questions from the floor? Anything at all? Specifically about Mike's career? Okay, I'll just check in with Claire. Anything from...
Not from that. We have a question for later on.
Excellent. Okay, well, we'll move on, Mike, in terms of your career. Let's move on now to COVID-19. Inescapable topic of our time. So, first question here, Mike. We're still in midst of arguably the largest public health event in living memory. Could you briefly outline for us the role that the WHO has played during this pandemic?
I'll try very briefly. First of all, to explain to everyone who cannot be aware, I mean, yes, WHO is seen as a building in Geneva, and a secretariat and a bunch of doctors, nurses, public health practitioners, logisticians, and others who work on this. WHO is a membership of 194 countries. So our primary job as an organization is to carry out the will of all of the member states of the organization. And that stretches all the way from health policy to health care delivery to vaccination. I run the emergencies program, the emergencies part of the organization. And our key role is in detection, characterization, understanding new diseases or old diseases, understanding their impact, deploying international teams, building the best evidence we can for how to contain those diseases, stimulating the research that's needed, and setting out the evidence and building those global standards that allow us to respond. So WHO has been in every single part of that, on the public health, the surveillance, the deployment, the logistics, the training, the emergency medical teams, the epidemiologic analysis, in modeling, in clinical trials, vaccine trials. So but I think our primary role as an organization is not to do everything. It's to coordinate, it's to make sure the right things are being done and make sure that our fantastic partners all over the world, be those partners in high scientific national institutes of health doing primary research, or be those partners in the front line, NGOs responding on the front line and saving lives in COVID, and particularly supporting people in fragile countries and countries affected by conflict. So we'll be working everywhere from a refugee camp in Syria in COVID all the way through to a global conference on new therapeutics and design of new molecules for antiviral therapies.
Okay, thanks, Mike. Next question from me. Now, don't worry if you can't answer this. This is tricky, but please share your thoughts on, do you think eradication of COVID-19 is still possible with large-scale public health measures, or is elimination more realistic? Or do you think that COVID-19 is likely to become an endemic disease, something that we're all going to learn to live with?
I think option 3 there is the more likely scenario. We're not going to eliminate or eradicate this virus. What we can eradicate and eliminate is the death and suffering caused by this virus. And the two are not exactly the same. But in terms of the virus it's very fit, it's very adapted to humans. It will continue to evolve and adapt and try to evade our countermeasures. It's able to move into animals, as we've seen with mink, we've seen with deer, and it can move back into humans. Any virus can go hide in the animal kingdom and come back. Any virus that can evolve as efficiently as this virus does is very unlikely to be eradicated in the sense of smallpox, getting rid of the virus off the planet. But what we have the opportunity to do, what's in our power, is to eliminate the public health threat and to eliminate the death and suffering associated with the virus.
Thank you. Thanks, Mike. So, any questions from the floor for Mike Ryan on the topic of COVID-19, please raise your hands. Anything at all you want to ask a senior member of the WHO? Yes, we have a question at the back there. Yeah, if we get them. Yeah. My colleague is just bringing a microphone over.
Hi, Mike. Thank you very much. What needs to happen to vaccinate low to middle income countries of COVID-19? Everyone promises money and then it just doesn't seem to happen. Is there a lack of political will? Can they not see how important it is?
Yeah, you asked the question. We've had the most. So I didn't catch your name. We've had the most.
Yeah, it's Christina.
Christina, okay, hi Christina. We've had one of the most incredible rapid development in diagnostics and therapeutics and vaccines ever in the history of the emergence of any disease. Within days of the virus identified, we had a sequence, we were putting laboratory assays, we were distributing PCR tests within 3 weeks of the virus sequence. And at scale, we developed vaccines in months. This was one of the greatest scientific triumphs. And that scaling that vaccine production, again, was huge. And that scaling of vaccine production was done with taxpayers' money because countries pre-purchased all of that material regardless. We didn't know how effective the vaccines would be. There's very little risk in this for pharma because everyone got paid to produce regardless of the outcome of effectiveness. So you'd imagine in that situation when you have this collective purchasing of these wonderful new scientific innovations, that we could at least distribute them in a way where people, most of us, people over 65, people with underlying conditions, would at least, at minimum, be vaccinated first. It didn't happen. It didn't happen because people didn't. It didn't happen because manufacturers prioritized contracts from other countries. It didn't happen because promised donations haven't materialized. Only 50% of donations promised have actually materialized, and that was donations up to the end of the year. You can't stick pledges in people's arms, stick vaccines in people's arms. You can't stick promises in people's arms. So there's been a collective failure to recognize that the people dying from this virus are really people, who are older, people with underlying conditions, people living in marginalized and fragile situations who may have conditions that will complicate COVID, and we're not vaccinating them at enough numbers. And even in the West, even in industrialized countries, even in countries now that have, on the face of it, very high levels of vaccination, even in those countries, sometimes the most vulnerable are not vaccinated. Because we're not accessing people who are vulnerable. And there's a high, you see in Eastern Europe, high degrees of vaccine hesitancy. So even though the vaccine is available, people don't want to take it. And there's an issue of trust with government. I think our biggest problem in this pandemic is trust in government and trust between government. That's been the missing ingredient. Not science, not innovation, not solutions, but solidarity and sharing has been our greatest failure, not science.
Mike, that's such a powerful message, that solidarity, not science, that has prevented us from mounting an effective global response. And just to build on that question, what's your view on the issue of vaccine nationalism, this issue of Western developed countries hoarding vaccines and the lack of access to vaccines in the global south, and how we might perhaps redress that?
I think there are honest brokers trying to address that, and certainly over the last number of months we've seen an acceleration of vaccines coming through for low-income countries, but it's nowhere close to where it is. We're talking about 5 vaccines per 100 population in low-income countries compared to 140 or 50 population in industrialized countries. So there's still huge inequity, but the ship is beginning to turn. Manufacturers are beginning to honour their contracts and accelerate the contracts. Countries who have enough vaccine are stepping out of the queue and allowing contracts for low-income countries to go higher in the queue. And some countries of the north are donating vaccines and accelerating the delivery of those donations. Putting all that together, we're seeing an acceleration, but we're nowhere close to where we need to be. We've got, I think at this point, about 111 countries who are going to miss the deadline of 40% vaccines, 40% vaccination coverage by the end of the year. 111 countries of our 194 are already on track to miss that deadline because of the vaccine delivery issues, and some because of vaccine hesitancy issues. So yes, I like the way you put it at the end. We need to fix the problem now and stop describing the problem. A lot of pressure is being brought to bear at many levels to try and redress that. And obviously, we're very pleased too with President Biden's leadership over the last 2 months in terms of the summits that he's hosting around vaccine equity and delivery. Because at the end of the day, WHO can't put the necessary pressure sometimes, particularly in the corporate side, to get the necessary compliance and cooperation.
Thank you, Mike. And if you mentioned the topic of vaccine hesitancy, that's a huge issue at the moment. And if you're interested in that, we're having an online session with one of the world-renowned researchers on this topic, Pauline Paterson, who is doing an online-only session on this. So do have a look at that. We have a question from our virtual audience. Claire.
Good morning, Mike. Thank you. I've got a question from a lady in the audience, Semran. Her question is, what do you think is the best way to tackle misinformation, anti-vaxxer movements about COVID-19 on a global scale?
Oh, these are the real issues. So you're nailing it, everybody. For me, and this is a personal view, my view is we shouldn't be attacking the messengers. Misinformation is we call it an infodemic, and we've developed a whole new science of infodemic management. There's been a tsunami of information, some of it good, some of it bad. Some of it bad just because people are gossiping and creating and generating and continuing rumors. Some of it is targeted. Some of it is weaponized in terms of trying to disrupt programs and disrupt vaccination. So within all of that, you need different approaches then to dealing with that. Not all the information is bad, and not all the bad information is badly intended. So we need to really work hard to understand how we can generate the right discussion and the right information exchange at community level. And my view is never attack the messenger, engage the messengers. We need to get much better in the science, public health, and the health community at getting good information out quickly. What we're doing now, we have a system called EARS, which is an automated social listening system. We start to see trending topics that come up on the negative side or the positive side. And what we're doing much more is treating these information packets like viruses and trying to detect these particular things that start out at nothing. They're just a few people discussing, and then the next day there's 50,000 people, and then it's 50 million. We need to pick out what are the potentially dangerous trends in information, and we need to engage with that information, not avoid it. We need to engage, and we need to be able to get much better at putting good information into the system, vaccinate the system with good information, not attack the messengers. We need to keep our airways open. We need dialogue. Democracy is based on everyone being able to have their say. So my view is we should be really, really avoiding shutting down the negative voices. We need to engage. And that means we need to get much better at what we do. Now, those very, very small number of people who are actively weaponizing information to disrupt public health interventions, then I think you may have to take a slightly more shall we say, a harder approach there in ensuring that systems and communities are not being actively undermined, both either from within or outside the state.
Thanks, Mike. I think it's such an important point, is that that difference between true anti-vax and vaccine hesitancy. And people who are vaccine hesitant may have legitimate concerns about the safety and other issues around that vaccine. And as you say, they need to be meaningfully engaged and not excluded from the conversations. I think that's such an important point. Well made. Thank you. Let's move on, Mike, from COVID-19. I'm sure we've all had enough of this already. So let's move on to global and public health. We're going to broaden the agenda now. So have a think in the audience if you've got anything you want to ask Mike on this topic. As a starter for 10, Mike, I'd just like to hear your perspectives as a founding member of the Global Outbreak Alert Response Network. It's really vital initiative. Can you tell us what that is? It's the GOARN. What is it and how it came about?
It's a worldwide network of about 50 institutions and other networks that includes organizations like WHO, Medicine Sans Frontières, UNICEF, Center for Disease Control, Atlanta, most of the really top public health institutes in the world, north and south. It began in the year 2000. From 1995 until 2000, we had a whole series of emergency diseases. We had Ebola in Kenya, we had Ebola in Uganda, we had antimicrobial resistance emerging, and WHO was being asked more and more to go to the field to investigate and support. We were arriving in the field, and our colleagues from CDC would arrive, and MSF were already on the ground. So we spent a lot of time competing, duplicating, and we'd all arrive with epidemiologists, but everyone forgot the lab people, or we'd all arrive with lab people, and everybody forgot the ecologists. So the idea here was to recognize that no one institution had all of the capacity, but together we could provide a much more integrated, multidisciplinary, adaptable and scalable response, especially in frontline. So GORN has been constituted Born has no written rules, but Born is, if anything, a social movement of institutions to solve the problem at the coalface.
Thanks, Mike. Okay, any questions from the floor? At the back there. We could get a microphone to the gentleman at the back left.
Hi, Mike. Thank you very much for an amazing talk and all the work you're doing. My name's Nathan. I've got a question about climate change. So from the WHO website, it says climate change is the single biggest health threat facing humanity. And as you said regarding COVID, we need to fix the problem and we need to stop describing the problem. So I'm wondering, what is the WHO doing to address the climate crisis? And is its focus primarily on preparing to deal with the health impacts of climate change or on trying to prevent it in the first place?
Thanks, Nathan. Well, we're able to measure what we think are going to be massive negative impacts associated with climate change, climate variability, and those impacts, are going to be measured in heat wave related cardiac conditions and stress, all the way through to drought related, food related, malnutrition, all of those effects. The fact that climate stress and climate change is driving epi-risk, it's driving the risk of outbreaks for cholera, for arboviruses. Right now we're dealing with a number of yellow fever outbreaks in Central Africa. We're dealing with the re-emergence of Zika virus in India. We have dengue. So these vector-borne diseases are very climate sensitive. Waterborne diseases, very climate sensitive. And anytime we pressure the biosphere, anytime we pressure the ecologic system, we can do it directly through our behavior, but we have a long-term trend that the climate is doing it for us as well. And it's creating huge uncertainty, new opportunities for viruses, new opportunities for vectors. And therefore, our job, yes, we need to get ready to mitigate the impacts, long-term impacts of that by adapting health systems. For example, in the Caribbean, we've been working with all the Caribbean countries just to build hospitals that are hurricane resistant. In fact, in some of the more recent hurricanes, the hospitals became the emergency centers for coordinating the whole response, because we're building these climate resistance hospitals which can actually not become victims themselves of the hurricanes and stay open when we have these events. And that's reacting and adapting and mitigating the impact. But we need to get further up the chain in terms of preventing those changes in the first place. But as you can imagine, that's not in our space. We in the health space have to advocate. We have to measure. We have to predict, and we have to measure these impacts. And then we need to go back up the chain to our political leaders and others and make sure they understand more and more that this is no longer just not. And I sometimes I get, we talk in numbers and 1.5 and 2.4, and we get caught up in the numbers. What you need to do is go to the Sahel and see agriculturalists and pastoralists literally killing each other over water resources that are being diminished by climate stress and climate change. The next wars on this planet are going to be over water. Water will become more valuable than gold or oil ever was. So the futurescape for many people with urbanization and migration, it's driving migration. And migration is driving instability in countries much further away. So we need to understand that climate change and climate stress and then you add in the social inequities that are emerging by other forces, and then you add in the health inequities that are generated in the system. And I actually think it's like three juggernauts heading down the road: climate injustice, health injustice, and social injustice, and they're going to collide. And we can no longer disaggregate those trends. And I think we're at a moment of the greatest threat we've ever had as a species and as a civilization. And yet, at the moment of greatest opportunity, our connectedness is our greatest weakness when it comes to viruses. Yet our connectedness is our biggest strength. How do we use our connectedness, our innovation, our creativity, and our desire to help our fellow person, to help our fellow man and woman, to help our own communities? How do we activate that rather than what we have now, which is a sort of a fatalistic view that the world is doomed, there's nothing we can do, we're going over a cliff? No, that is not the case. We do not. The future is in our hands, and it's still in our hands. And the question is, for me, and I always ask myself, what promises are we going to make to our grandchildren? Because right now we're not doing so good. So I think you raise a huge issue. I think as WHO need to do more and more and more to clearly demonstrate the existing impacts. It's not future. Climate change is having a direct negative impact on hundreds of millions of people around the world in terms of their food security, their water security, and their health security. And we need to maybe measure that better and make sure that we're there in the middle of those discussions that drive these decisions that need to be made right now.
That's incredibly powerful, Mike. Our interconnectedness as a global community is our greatest strength in tackling climate change. And the health impacts of climate change are a key theme in this conference. If that's something you're interested in learning more about, there are lots of speakers on this topic. If you have a look at the schedule, we've got Nathan Hudson-Peacock, we've got Professor Hugh Montgomery, Hugh's talking in the biosphere, and there are 2 breakout discussions on the topic of COP26 and what it did or did not achieve with regards to tackling this big issue. So do have a look at those in the schedule. Let's take a question from our virtual audience. Over to you, Claire.
Thank you. So, Mike, a question from Tori, if I may. What has changed in the global emergency response that we have learned from the pandemic, if anything?
I think lots. I think over the last 10 years, we got quite good at reacting to single country or multi-country outbreaks in a region and being able to investigate quickly, characterize and respond and contain the Ebola type scenario, cholera type scenario, yellow fever type scenario. I think what's changed, obviously, with the pandemic situation is we had every country affected very, very quickly, and then all of the demands for supplies, for therapeutics, for PPE, for all of that. And I think, as a global community, and including all the countries, we had built lots of static defenses. It's a bit like the Maginot Line, for those of you who are historians. We built a static defense, hospitals and things, and we checked off on the boxes. How many labs do you have? And how many response teams do you have? And how many things do you have in your stockpile, in your warehouse? And that was the kind of the assessment. And those of you at the extremes know this more than anyone. You can have all of that, those static, but it's your dynamic capacity to react to what you see. Was it Mike Tyson says, everyone has a plan until you get punched in the face, right? So, and it was that getting punched in the face, and then that lack of, that in sport, and many of you, I think, there are involved in medicine on the extremes of sport, and it's that dynamic strength and conditioning, not just how big I am and how much weight I can lift, but whether I can adapt to the real conditions on the field. What my level of adaptability, flexibility? Can I go higher, longer? What is the durability of my system? Can I sustain 150% effort for much, much longer than? And then can I change and adapt what I do? And it's not just by the numbers. So I think what we learned was the lack of dynamic adaptability, dynamic scalability of our systems, and then the inability to integrate the work across countries so we could share supplies and share vaccines and share other things. And not having that worked out in advance at a detailed level, I think has caused a lot of issues around the world. I think, what else have we learned? I think what we've learned is that our frontline health workers and so many other frontline workers are true heroes. They've kept our society going through 2 years. And I don't mean just health workers, I mean all those workers, all those drivers and all those postmen and God knows who else has gone out there in the middle of a pandemic and just kept us all fed, kept us all warm, kept us all safe. I think we've learned something quite special about what we can achieve. And I think we've also learned, going back to the hesitancy thing, we've also learned that not everyone is interested in positive outcomes, and that we have a lot of misinformation, and we really weren't ready to deal with the scale of that, and we need to be better prepared. So lots of lessons. They're not finished learning them yet because this pandemic isn't over, But I think if we're prepared to learn those lessons and really invest, you think about this, we spend $2,000 billion every year on security and defense around the world. And we've been defeated by a microscopic virus that's crossed our borders, ripped apart our economies, collapsed our educational and health systems, disrupted everything we find precious in our lives. And yet the proportion of money we invest in defense against those bugs is minuscule in comparison. So I think society needs to start telling our leaders, what do we want to be defended from? I don't necessarily want to be, I don't think anyone's going to march into Ireland and my country or into the United Kingdom or anywhere else for that matter and invade in the next 3 or 4 years, but I guarantee you we'll have another pandemic before we know it, the way we're going. So I do think we've learned that we're maybe investing in the wrong kinds of defence.
Yes, Mike, it's remarkable how ineffectual a fleet of Trident submarines is going to be against a virus. Now, we've talked about COVID-19, we've talked about climate change, vaccine hesitancy. But in 2019, the WHO published your list of top 10 threats to global health, and there are other threats. I mean, if you look at this list, it's sobering and it's vast. So this includes non-communicable disease, other high-threat pathogens, antimicrobial resistance, dengue, HIV. Which of these other areas do you perceive as the next biggest threat to humankind? And what could the frontline health workers in this room and watching online, what could they do? What is within their power to make a positive contribution or an impact on that area?
We're all going to have, shifts in what potentially going to negatively impact our health in the coming years. And it depends where you sit in the world, right? It really depends. But we'll always have those threats of pandemic diseases. Antimicrobial resistance is a huge issue. We're running out of ground. We're using up our 9 lives. We may end up with organisms that are completely resistant to all our therapies within years. So that's a huge issue. I think the animal-human interface, this concept of One Health, recognizing that it's at the boundary of the environment and the biome and the animal kingdom and our kingdom. The health of animals and the health of our biosphere is directly impacting us, and we're directly impacting it, and the same in terms of the environment in general. And I think addressing that as a major issue, it will, if we don't address that interface in a more systematic way, we're going to suffer across a range of health issues. But it's if I look to the future in terms of emergencies, with climate, with conflict and fragility, it's amazing to be in 2021 and look at how many people are hungry in the world. How many people are, I don't mean just hungry occasionally, I mean suffering from massive food insecurity. And I think food insecurity and water insecurity are going to be major health threats in the coming years unless we do something about it for so many different reasons. I'm not going to sell the pandemic risk because it's there and it's always there and it will always be there. But I think there are other risks. I think our lifestyles, the way we're living, the obesity crisis, and all of that is a major tsunami of, as we get older and as populations live longer and as we bring more chronic disease into older age, the health and welfare of living with dignity into older age is going to be a major issue, because there is a huge problem in many countries in the way everything is structured, not just healthcare, pension programs, and many other things. So I think the health status of older persons is going to be a huge potential positive for how we treat the oldest and wisest of us, but also a massive potential for harm and poor health. And I think one under-recognized, I'm so glad it's been recognized now, and it wasn't in that list, in the list we've made in the past, and that is mental health. I think the pandemic, so many other things, social, economic stress, our urbanized, high energy lifestyles, everything that leads to, again, a pandemic of mental health issues And I think we need to watch out for that clearly as WHO and invest much more in mental health. So you'll see, I come from an infectious disease background and an emergencies background, and I'm talking about food, and I'm talking about obesity, and I'm talking about mental health, because I think WHO must look much more broadly. It's not just about waving shrouds for pandemics every day. There are pandemics of everything happening. The only difference with this pandemic of COVID is that it's the tsunami rather than the slowly rising flood. It's the thing that hits you in the middle of the night, sudden onset disaster. But we have so many slow onset, creeping disasters that can be managed, and that's the issue. With a little focus on social equity, with a little focus on health equity, and giving people basic access, the basic human right of access to preventive and curative healthcare at the primary healthcare level, so people can better manage their bodies, better manage their mental health, and giving people the basic skills and tools to, eat well, live well, think well. I think is the biggest challenge we're going to face in the coming 10 or 20 years, and I hope we can meet that challenge. I'm a bit concerned because I think health systems are becoming more and more inequitous, and in many, many countries it is just not possible to access healthcare without massive financial harm to the family. I know people, colleagues of mine working in developing countries, who actually haven't sought medical care for really serious conditions that they have, because they know that by doing that they could impoverish their kids and the next generation. To think that people are making that choice on this planet is incredibly depressing.
Thank you, Mike. So you've talked about antimicrobial resistance, the obesity epidemic, and mental health, and the shadow pandemics of mental health, delayed cancer diagnosis, cardiovascular disease. This is something that me as a frontline GP, I'm seeing every day. So it's fascinating the wide range of impacts that the current pandemic is having on other health determinants of health. And of course, the important issue of food insecurity. So it does seem very bleak sometimes, doesn't it, when you look at the myriad problems that the world is faced with. Let's shift on to one of our final topics now. Let's look to the future now, Mike, and let's try and lighten the mood slightly. So let's think about this question. Humankind invented antibiotics in 1928, performed the first organ transplant in 1954, eradicated smallpox by 1980. What do you think will be the next big medical milestones in the decades to come?
That's a good one. And just like the last one, everyone can do something, and that's going to lead into what what I'll say about this. In epidemiology and public health, and in my work, we're often trained to think in population terms. We're almost trained like vets. We think in herds. N equals 10 million, 15 million, 7.4 billion. And you as a jobbing GP at the front end, more than anyone, N equals 1. N equals that person sitting in front of you in a life crisis, in a health crisis. N equals, and every single frontline worker, be you in the emergency room, be it a health counsellor, be it someone working in the social services, everyone has the opportunity to turn that tide. Everyone has an opportunity to contribute to a more positive future. And I think we have to take our messages into a much more positive territory. There is so much we can do. There is so much we can achieve if we work together. With regard to the next big thing, having worked on polio for so many years, I don't know, can you still hear me? Because I lost your face. You can? Okay. Polio. We've only had 2 cases of wild polio virus on this planet this year, and they happened last January. We are effectively 10 months without a wild polio virus case, and in fact, even in environmental sampling, we're finding it very hard. Only, I think, over 2% of the samples are positive for a wild polio virus, in terms of vast environmental sampling done across Pakistan and Afghanistan. We've never, ever been so close to eradicating, for the only second time, a virus on this planet. But all of you know the situation in Afghanistan. All of you know the situation of the health system, the situation of women and girls and others. So for me, it's my greatest hope that in the next couple of years we could eradicate. We have a major problem in that is a zone of huge conflict. I think that's probably the biggest milestone. For me personally, one of the milestones that I think we could cross, and it's not an outcome, and that is at the end of this month, in about, I don't know what date it is today, I forget my dates, but in 15, 16 days' time, all the nations of the world will gather here in Geneva for an extraordinary World Health Assembly for only the second time in the 70 years history of WHO. And they're going to sit together for 4 days and they're going to consider whether we can construct a treaty, a binding treaty that will bind countries to how we prepare for the next pandemic and how we share better the results of our innovation. So for me, in terms of milestones, if we could get all nations in the world to agree on how we're going to prepare for, protect our populations and serve them better in the next pandemic, then that will be a huge milestone. A lot of work to do after we get that agreed, but it will be a huge milestone. So there are lots of things coming up. Certainly genomics and the ability to engage, genetic sequencing, our understanding of the human genome, our ability to intervene and individualize medicine. There's so much happening in terms of vaccines for cancer. Look at the HPV vaccine. I mean, and you know that as a GP. I mean, it's completely changed the landscape of cervical carcinoma already, only a small number of years after its introduction. And I believe we can make cervical cancer a disease of the past, again through vaccination. So lots of things out there on the horizon, and I'm life's great optimist. I may speak in negative terms about where we are now, but I think there's so much we could achieve together over the coming decades.
Yeah, there's so much we can achieve, Mike. That's a really positive note to finish on. And one delegate has mentioned the issue of artificial intelligence and how that might transform the way we practice health. There's so much more we could talk about, but I'm afraid that's all we've got time for today. So I'd like everyone to put their hands together in appreciation for your valuable insights today, Mike.